Welcome everybody. So good to see you. We've got a great group of folks joining today. This is a terrific turnout. Just to make sure you know where you are, this is the AOT Monitors chat session. Great to have you all. We've got a nice mix of kind of folks who have been at this for a long time, and mixed with some people who are just kind of getting started and been at this for a year or so. And then we have a few that are in communities that haven't yet kicked their program off. We wanted to make this relevant to everybody. So we've got a couple of questions we're going to kind of pose just to kind of get the conversation going. And then we'll save the second half of the meeting just for you guys to kind of throw things out there that you'd like to chat about. So one of the questions, we'll throw this out to some of the folks who have been at this a while, but a question that we get asked regularly is, how do you engage some of those really difficult to serve people? Folks who, what do you do if they're not showing up? You've used all the tools in your toolkit, and what suggestions do we have? And we remind people that AOT is not a cure-all. There are some people for whom just simply doesn't work, but there are a lot of things you can do before you give up. So I've asked a couple of folks to give some thought to this so they could kind of kick off the conversation. So I wonder, Marla from Youngstown, Ohio, are you if you'd be willing to maybe talk about a particular case where you had somebody who was really struggling, and what your community did to reach out to that individual and get them engaged. So.
Hello everyone, my name is Marla Golick. I'm with the Mahoning County Mental Health and Recovery Board, and I'm the AOT coordinator. Our clinical director couldn't be here today, so she typically would be stepping in on this role. But I've been here about 17 years, so we've kind of seen our program just kind of take a lot of faces on. We actually had a particular client who was homeless, transient, multiple hospitalizations, both in Ohio and PA, and not staying in one place too long.
I believe our city attorney did.
Oh, apologize, Marla. I'm just going to interrupt. If folks can mute yourself if you're not talking, that'd be great. Thank you. For those of you who've just coming in, if you just put your name, how you're connected to AOT, where you're from in the chat box, appreciate that. Marla, sorry about that.
That's okay. That's okay. So she has 7 children that she was unable to care for. On her last admission, she set herself on fire in a suicide attempt. Our navigator at the hospital advocated for the AOT with a plan to refer to our ACT team and then have her step down to our crisis unit. Also referring her to a residential transitional facility and using our multi-system funds that we have available in the hopes of getting her to independent living. In addition, she was assigned to our Fresh Start court, which I don't know many of you that know that or not, but it's a program that we've started with our probate judge, where they attend sessions up to 2 times a month. The client said she was willing to obtain stable housing, and her goal was to be able to care for her children. But before discharge, of course, our navigator met with her, told her all the expectations, things like that. But she was not happy with the results of the court hearings and being placed on an AOT. So when she was discharged from the hospital and stepped down to the crisis unit, she immediately left. She called the court and the navigator and said she wanted off the AOT. She wanted, she didn't want to go to court, none of it. She just didn't want to have anything to do with it. But after reinforcing the risks and the benefits of being on the AOT, she begrudgingly decided to come back to the CSU. But this was her theme throughout the whole involvement with the AOT. I mean, she literally tested every clinical recommendation presented to her. but the black robe effect did appear to motivate her, and she did maintain some type of compliance. So she started attending court regularly. She met with the ACT team. She attended the appointments, but it seemed superficial. It just seemed like she was just going through the motions. She still continued to make poor decisions about her living situation, moving from place to place, and she never sought the help of her ACT team. So, you know, the whole team constantly treated her with respect, honesty, warmth, tolerance, giving positive and constructive feedback when appropriate, and even at times radical acceptance. So the judge really demonstrated genuine care for her and for her well-being every time he saw her. Discussion every time in court was focused on her goals, barriers that needed to be addressed, you know, and support and what she needed to achieve. So once she started trusting the ACT team was when we started to see a real change in her commitment. She was independent about taking care of her needs and slowly began to seek the assistance when she hadn't accepted it before. So currently she has her own apartment. She's maintained compliance with treatment. She's found employment through our workforce development program, and she's begun small visitations with her children. I will say her mother is caring for a few of the children and kind of pushes back because she knows the background. But all in all, you know, she's doing much better. She, you know, and it really was just the whole team just coming together and just basically saying, you know, let's just do what we can to make her, you know, live a better life. So, you know, she was probably one of our most challenging.
That's awesome, Marla. I think it really, I mean, I imagine there were times where you all were ready to throw your hands up and give up, but it doesn't sound like you guys were.
Absolutely. Right.
It's a great reminder that this process takes time. And you really need to be in it to go the distance, because these changes don't happen overnight or in 90 days even, or half a year. So yeah.
Well, and I will say too, once her continued commitment hearing came up and she was placed on a year commitment, she kind of like fell backwards a little bit. She was thinking that she was just going to be free to go and, you know, just free to do whatever she wants. So she kind of pushed back a little bit, and we are seeing some struggle with that. But again, just reinforcing that we're not here to, you know, oversee everything that she does. We just want to offer it to her, so in case it comes down the pike that she does need it. But you know, we constantly question, should we maybe have terminated that and just, you know, seen what happened? But again, her background, we just didn't really want to give that an option. So.
And another good illustration of this isn't a straight line process either. You know, it's 2 steps forward and then a step back. So good for y'all for hanging in there.
I'm curious if other folks have stories you'd be willing to share where you kind of had to take a step back and look at the individual and what their specific needs were. If you have any an example you could share with us as somebody who it didn't look like it was going to work and you thought outside the box, you know. Anybody?
I'm Nick Schrantz from Butler County, and in Butler County, we do commitment hearings every 6 months, and we don't have a preset limit on how many renewals of commitments we can do. So I was visiting a gentleman in the community 2 days ago, and he's been on civil commitment since 2008. And in 2008, he was one of my most high profile people, someone I was literally chasing around the county to figure out where he was, what we could do to assist him, getting kicked out of group homes, getting kicked out of other residential settings, et cetera, et cetera. And I think we all kind of have a good idea of our clients and those, you know, the high acuity users, and then kind of the middle of the road people, and then the people who are quite stable and we don't have to see nearly as often. And this gentleman moved down that continuum to the point of where I have a model for how often I see people, and that's only if they are non-compliant, if they're arrested, evicted, or go to the hospital. And so for the last several years, he's done so well that I've said to him, I probably won't see you until your next court hearing. Then I'll see you before the hearing just to get an update from you. And that's because you're doing so well. And that continued and that continued. And his doctor still felt that he did not have the insight necessary to continue treatment without the court supervision. And we had a very positive civil commitment renewal hearing back in early January. He was praised for his success in treatment, et cetera. And 2 weeks later, 3 weeks later, he felt suicidal and wasn't going to go to the hospital with his family, who was trying to get involved. The police were contacted because he was in the family member's car and was threatening to jump out. I think the police officers were CIT trained, and I'm going to put in a plug for that because they were able to figure out where the mother was who had my client in the car, and they were able to talk with him, get him to go with them to the hospital. He was treated for a week and sent back home. And I met with him the other day, and he was describing the situation. The family believes that a increase in caffeine use made him hypomanic and throw off his equilibrium a bit, even though he continued to be med compliant. And so he continues under civil commitment, and it's just an example of a case where 2008, he struggled with a major mental health disorder. Throughout the last 14 years he has, and even now at a point of what we consider to be real stability, he had an adverse event, and he still remains under civil commitment, which I think gives him a feeling of support. And it certainly makes his family feel that they're being supported. And so that's why in our court, we have folks who are under civil commitment for 1, 2, 5, 8, 10, 15 years. And so that's my example recently.
Thank you, Nick.
And I think it's so important that the teams recognize and reaffirm each other that just because someone has a relapse, that can just happen. Everybody can be doing everything right, but mental illness is tricky, and relapse can happen regardless. And it's never a failure. Don't look at relapse as a failure. Always look at it as a teachable moment, I would call it.
And that's what we, the other day when I was talking to this young man and his sister outside, and it was, that it was us complimenting him for telling his family that he felt suicidal. And so even though he was initially refusing to go, complimenting him that it was helpful to go to the hospital. And like you said, Amy, not a failure, but an example of something he needed at the moment. I pointed out to him, because I first picked up his case from the state hospital, that going to the hospital for 5 to 7 days to get your meds examined, to settle down, et cetera, was certainly a reasonable thing to do, and it didn't necessitate something down the road of going to the state hospital, incurring a legal charge or anything like that. And I think he understood that the hospital can and should be a good thing and a good option when it's needed. And as you said, with the cyclical nature of mental health disorders, that's going to happen.
I apologize. I neglected to introduce the Treatment Advocacy Center staff that's on the phone. I had everybody else sign in, but I just wanted to, I should introduce myself. I'm Betsy Johnson, Policy Advisor in the Treatment Advocacy Center Implementation Team. And I'm joined today with two of my colleagues, Amy and Brooke. So I'll let them just say hello real quick.
Hi, everyone. I'm Amy Lukes. I am the Director of AOT Implementation. I'm coming to you from Minnesota and so tickled to see so many new faces here. I just absolutely fabulous. So thank you for joining us.
Brooke?
Hey everybody, I'm Brooke Gentry. I'm the AOT implementation coordinator on the implementation team with Amy and Betsy. And my role is to kind of be our glue and keep us organized and coordinated, and then also manage our AOT learning network, which I assume is how many of you found out about and signed up for this meeting. So happy to be here, and I am zooming in from Atlanta.
Yeah, as Amy said, so terrific to see so many new faces. Just for those of you who are on this call for the first time, it really is we try and identify just a couple of questions just to get things started, but it was really your meeting, and hopefully, feel free to chime in or ask a question, or if you're running into a barrier or a problem, you want to hear how other folks may have addressed it. This is your chance to do that. I did have one other question that I wanted to kind of throw out there. I was going to ask Benito to talk a little. Benito's program's been around, I think, going on about 2 years now, Benito, I think, going on 3. Is that right?
We technically started March or April of 22.
Oh, okay. So
that's when we had our first hearing.
So just about a year.
Yeah.
Hot diggity.
Happy anniversary. So I asked Benito, since being a new program, to share maybe a barrier or two that they have run into getting their program up and running and how they addressed it. So Benito, I'm going to turn it over to you to share that with us.
All right. First, hello, I'm Benito. I am the AOT monitor for our Ellis County area here in Hays, Kansas. We're a town of, I think, 25,000 people. So we're not too big, not too small, just right. One of the barriers we have here in our county area, we're pretty rural. The nearest town that's of a good size is probably 2 hours away. So some of our barriers are getting resources, just simple as transportation, communication, and those type of situations. So a barrier with some of our consumers was transportation to getting to hearings or to just their medical appointments. Those basic appointments they need to just continue getting services. Through the grant that we got and just working with community partners, we started working with our local bus transportation place to access some bus tickets for our participants to use. We communicated with our case managers, talked to their treatment teams to see if, hey, can you give this participant a ride to their next appointment? Can we have you join their appointment with them to kind of understand what's going on? Their primary care providers sometimes don't get the full picture of what's going on. So having their treatment teams, go with them definitely helps. And it helps us understand what they're working on as well. We educate our participants on how to call and set up transportation. Through our programs, we help them get on Medicaid. So a lot of people don't realize that you can get transportation to these appointments through their Medicaid providers. So we develop little sheets of, hey, this is what you call, this is the number you call. And we've talked to the ones here in Kansas, at least, to get a gist of what the conversation looks like. That way we write it all down for them with the answers that they need. So when they call by themselves, they have a little cheat sheet of what they need to say at certain moments, which improved our appointment follow through, and it really reduced our no-shows. At least that's what we saw happen with that barrier. With communication, a a lot of our consumers were getting out of jail. They were getting out of Lawrence State Hospital. They don't have many funds, so it was hard to get in contact with them once out in the community. We provided smartphones and phone cards to participants. We understand that we can't continue doing that because it gets costly. So what we do, it's we give them a smartphone with a phone card for a month. And while we're doing this, our treatment team or we apply for the government assistant phones such as SafeLink or QLink. And usually within the month, if they fit in AOT criteria, most likely they'll qualify for that service, is what I'm starting to see. So with communication, we give them phones, phone cards, get them started with government phones as well. And that's the biggest thing there we've seen is improved communication with our treatment team. They contact, if they need help, they're able to call somebody for assistance. And just building that confidence and being able to go on the community and set up those rides with Medicaid and bus tickets as well. So they kind of play into each other. The biggest one of all these three was participant adherence to treatment. Like I still struggle with this at times. How do we get our AOT participant to buy in to this program? How do we get our AOT participant to say, hey, you're not just going to throw me back to our state hospital or jail if I start participating? Sometimes family members, the best way to approach this for us has been engaging family members, engaging treatment teams, and the stakeholders, such as the law enforcement officers, corrections, and court services. So we try to keep an open line with them to help that communication. So many of our participants are involved in the ACT team, and they're involved in, they're in court services likely or corrections. So having that open line of communication between all our agencies definitely helps us pinpoint what's going on and kind of guide each other in a sense. Maybe the corrections officer is getting frustrated because our participant hasn't showed to their appointments, and they're wanting to incarcerate them. But instead of doing that, we try to talk to them and find other solutions at times. And sometimes our incarceration is what's needed. Not needed, but they can't avoid it at that point. But one thing that's really been helpful, for example, educating family members on the participants' lack of insight. That has been a huge thing for us. I was on the phone, I think it was yesterday, with the mom. Her son has been violent towards her. He struggles with schizophrenia. Son has been violent towards this mom for easily many years. We just got him on the case about 2 months ago. And before this, mom has been taking care of everything. Everything from daily needs, managing stressors, never contacting law enforcement for any crisis. So when we got them, we kind of just uncovered all these things that mom was doing. And what we found out was mom was getting overwhelmed by doing this all by herself. And then once he got into the program, we were able to help him access the ACT team. We helped access the law enforcement center. And just recently we did a care assessment to find a higher level of care due to finding out that we weren't enough as well. This individual needs more assistance than we thought we could provide due to the physical barriers. So the mom yesterday voiced that she was really happy that they even got involved with the AOT system, because without that, they would have never understood that he wasn't following through with treatment because he didn't want to, but because he couldn't due to illness and nausea. Probably botched that, but his lack of insight. But those are our main barriers right now.
That's awesome, Benito. Thank you so much. I love that last story about educating the family members. I just wanted to let folks know who may not be aware of this, but we have Treatment Advocacy Center put together sort of a guide for families of loved ones who are either in AOT or their family is seeking to get them in AOT. It's just a primer on what it is and kind of what the role of the family is in the program. and it talks about anosognosia. And it also reminds families that, there's a role for families. They can be supportive. We don't, and it just does a really nice job of just laying out all the information that families need to be good partners with the rest of the team and help engage and be supportive and not get in the way either. Brooke, I wonder if you wouldn't mind sticking the link for that in the chat. And feel free, this is just a sample document. You all, if you wanted to, use it for your programs, feel free to make it your own. You can cut and paste, or you can, modify it, do whatever. It's just, it's out there for your use. But that's wonderful, Benito. Thank you. I saw we had a question in the chat box.
Wait, Kelsey's got
sorry.
her hand up. I know you
Oh,
can't.
I'm sorry.
Hard to keep track with all these folks. So Kelsey, thank you.
That's okay. Thank you. So I work for Santa Clara County. Our program's about a year old, although we just started the petitioning for civil commitment process over the summer. So we've petitioned 6 people. And I do have a comment about the meth issue, because it's been a big issue for our program, the meth-induced psychosis, particularly because we get a lot of pushback from the hospital system, where, like, when they go to the hospital, they just release them right away because they say, oh, it's just meth, and kind of dismiss them. So we're really having a lot of trouble getting, like, people to the appropriate level of care when it's meth induced, because the physicians in the hospital system just kind of don't want to deal with it. So if anyone has any thoughts that you've seen success with meth, I know the best treatment for meth, my background is in substance use, so that's kind of my expertise, but the best treatment for meth is something called contingency management, but it's not really offered in our county. And then the way the laws are in California, if it's substance induced psychosis, there's not that much you can do in terms of involuntary commitment. But what I raised my hand about was, I'm interested if people have experiences or ideas about getting people to show up to court and what has worked to get people to show up to court, because what we have seen in our kind of small sample size is, like, if we can get people to show up to court, we can usually get them to agree to the treatment plan. But if they don't show up to court, then we have this hearing in their absence and they're ordered to AOT, and it's just like a piece of paper. It doesn't mean anything to them, and we don't get any compliance. The one success story I would say is someone who had a serious violent incident. So he was ordered to AOT, then he had a serious violent incident and he went to jail. And then he was there after that, really motivated to participate in AOT because he didn't want to go back to jail. So he's doing really well right now. And we have him housed, and he's taking medications and all that stuff. But everyone else who hasn't made it to court, we haven't made any progress with them. So just curious if people have ideas for how you get people to show up so they can actually benefit from the black robe effect.
So Kelsey, if you're speaking in terms of, like, I mean, I kind of, keep them separate. AOT and Fresh Start Court are intertwined, but they're also 2 separate courts. So the continued commitment hearing is one thing, and then the Fresh Start Court is another thing. Our judge, with regards to Fresh Start Court, and I will say this, a lot of it falls on the case managers. I mean, we have great case managers within our providers that make sure the clients show up for court. If they don't, they make an effort to, just within their means, make sure that they can get them there. Fresh Start Court is basically, somebody asked in the chat, it's basically just a a black robe effect. I mean, it's basically where the client presents in front of the judge, however many times the judge rules it. It was a program that we based off of Judge Stormer, that I believe she started. Betsy, you might want to help me. I don't know if she started it or.
Well, I think, Marla, a lot of it's the check-in component of an AOT program.
Correct.
It's that part where the individual is coming in periodically to check in with the
Yes.
court. It's kind of, most programs see that as part of the AOT process. It's just
Right.
it's not the formal hearing or the continuation, but yeah.
Right. So, you know, a lot of the times, I mean, our judges actually find the client when when they don't show up. I mean, they don't ever get paid, but I mean, you know, it's, you know, he really goes above and beyond to make sure that they engage and to let them know, you know, this isn't a joke. This is something that we just want to do to help you to make sure you're med compliant, you're complying with your appointments, you know, some type of housing, some type of job, if that's a possibility. So, you know, our judge and our probate, they do a phenomenal job. So, but like I said, it obviously everybody can speak to this. It really is a team effort. So.
Kelsey, do you provide transportation?
So that's part of the provider's responsibility is transportation. But yeah, we've had transportation there ready to go. The case manager's there, but they just don't want to go. So, yeah. And I think we're maybe more limited in California in terms of the consequences for not showing up, because no, there can be consequences or. Yeah.
Basically, the consequences are you have to wait until someone deteriorates and
Right.
then an emergency evaluation. But AOT doesn't have consequences that, you know, that a mental health court might have. You never find someone in contempt of court and put them in jail. So.
Kelsey, I know some programs, the hearings or the check-ins are actually held at the provider agency. And they're trying to time it with when they go in for their appointment or go in for their medication. And then the judge has sort of the hearing room set up at the agency to reduce the burden both on the, you know, the treatment providers getting them back and forth to court, but also making it easier for that individual. And then oftentimes they prefer that setting because they're more comfortable in it because they're familiar with it. It's not as intimidating. I know there's a judge in Lorain County, Ohio. I don't know if we've got anybody from there, but I know when folks don't show up to his court, he actually writes them a note, you know, mails them a letter saying, we missed you today. Really, you know, disappointed you weren't here. Looking forward to seeing you on, and then they give them the new date and time. And believe it or not, that often works.
Cool. Yeah. And yeah, we have talked about moving venues out of the courtroom, especially for the check-in sessions. But I'll tell Judge Manley that he should start writing people notes when they don't come to court.
Judge Manley is doing your court?
Yeah. Yeah.
Oh, that is so amazing. We love Judge Manley. Love Judge Manley.
Other ideas for Kelsey in terms of how to get folks?
Kelsey, we often remind people that if their goal is to get the court dismissed, the only way they're going to get it dismissed is to be compliant with treatment to the point where their treatment provider makes a recommendation to the court that they no longer need the court supervision. The same sort of process applies if they don't come to court. You can educate the respondent that they're not going to have their case dismissed if they're never showing up at court to have the case dismissed possibly. So we try to use that incentive to be done with the court as an incentive to show up for court, to show up for treatment appointments, et cetera.
So I wonder if we want to get back to the meth issue. I know that came up in the chat box in terms of, you know, I know that's a real problem for folks in terms of people still using and testing positive for drug screens. Just wondered, Amy, I wonder if you want to talk a little bit about the whole, drug screen process as it relates to AOT.
All right, so a couple things. One, we have not seen really good outcomes for people with methamphetamine addictions. It's such a pernicious drug. I mean, it causes psychosis. And it's recovery from it is so difficult. I think more so than any other drug that's out there. At least with opiates, we have medication-assisted treatment. We don't have that for methamphetamine yet. Hopefully at some point we do, because I really don't see a way out of this issue without something like that. Now, I'm going to say something controversial, but I don't think AOT programs should be doing drug screens. This is a mental health civil court. If someone turns up with a positive drug screen, what are you going to do? I mean, as we just said, there really aren't any consequences. I'm a firm believer in integrated treatment, which means integrating mental health and addiction treatment, preferably on the same treatment team, and addressing both issues at the same time. The research shows that's really what works in this population. And I know for many judges, that's a tough sell because, that's what they're used to. But taking an abstinence-based approach with someone with a severe mental illness rarely works. You really do need to take more of a harm reduction approach. And I would say the same is true for those people that really don't want to engage. It's take a harm reduction approach also with their mental illness. So that's my 2 cents on that.
And Amy, I think the harm reduction approach then dovetails into my thought that an AOT program can still be effective for people who have a major mental health disorder and a co-occurring substance use disorder. Meth is rampant in Southwest Ohio, where I work. We have multiple respondents who we are able to keep in psychiatric treatment. It generally consists of some meetings with case management, enough appointments to be up to date with a psychiatrist or a nurse practitioner. And generally, we are able to incentivize people to receive their generally monthly long-acting injections. So we're able to provide the psychiatric piece, the main goal of the civil commitment order. We certainly don't achieve stability because the meth use destroys treatment plans, stable living situation, group home placement, the ability to stay out of jail and all those other things. But I would advocate that we should not spontaneously dismiss a civil commitment order if someone has a substance use disorder that threatens their stability, because we often can continue the psychiatric treatment in hopes that at some point the substance use disorder becomes better treated.
Yeah, and social worker here, not doctor, not nurse, no, not a real medical professional. And I don't play one on TV either, but there really is no contraindication in prescribing antipsychotics and people using drugs. It's not a problem. And when I was a case manager, 100% of my clients were dually diagnosed, and the ones who needed antipsychotics got them. That's not true for all psychotropics for sure, but for antipsychotics, it's pretty clear. And I think that I read that where antipsychotic use in treating meth-induced psychosis does work, so.
It looks like we have another hand up. Kate, you have a question? Yeah.
Yes, thanks. So in Michigan, our AOTs, well, our court has the hearings still virtually, at least last I knew, so that people, you know, that are subject to the AOT can just connect on via their phone or computer. And then non-compliance, we have the non-compliance pickup orders. So because I'm a NAMI board member and also on our community mental health board, our youngest son, who is 34, has been under an AOT, and I've gone I've gone the route. I've had a lot of experience with it, and he was picked up for non-compliance of meds, and becomes, you know, otherwise becomes very violent with police. It was really very traumatic for everyone. And it didn't, even though the CMH had petitioned for the pickup order for non-compliance, they did not, and this was for not taking a medication, a long acting, they did not show up at the emergency department once the police took him there, and nothing got done. He was there for 4 or 5 days, and he ended up catching COVID, and then the AOT expired and they didn't renew it. But in any case, our probate judge, family court judge is really good, and they do have these hearings, and Ben went to most of them. But there's no check-in here. When you guys were talking about court check-ins, there was no requirement for him to check back in with the court. And we've helped other families through NAMI understand how these AOTs can be petitioned by anyone here in Michigan. I don't know if that's the case in other states, but hospitals should be doing it. Police officers should be doing it. Families doing it. But those are some of the things that I've noticed that are different. We also I don't see, you know, like in his AOT order, treatment plan, there were no drug screens. And I agree that really doesn't make sense, because there's already enough going on. You just want to try to get, you know, some mental health treatment in place, and then hopefully the rest will follow. So those were, you know, I also want to put a plug in for NAMI. I want to see the Treatment Advocacy Center pamphlet for families, but boy, we have some amazing classes and support groups so that families and natural supports are better able to help their loved one, because we could be a trigger, families can be a trigger. And I really think that a lot of the system underestimates the value of families and natural supports for adults. You know, there's this huge focus on the families being involved with the kids. Well, a lot of our adult kids are still kids, and we need, you know, we have a guardianship and others, we still need to be involved. It's essential. Or it could be a best friend or some other natural support. And I really think we have to advocate for those people being involved, which gets us into HIPAA. That's a whole nother story. But anyway, that's all I have to say. Thanks.
Hey, Kate, I say Brooke put the guide in the chat. I'd hope, please take a look at it. We actually worked closely with NAMI Texas to develop that guide, and but would love, you know, it's a work, you know, all of our products, you know, are constantly evolving and improving as more people read them and make contributions. So we'd love your feedback on that, if you would. Don't hold back if there's something you disagree with or want to, you know, fix or improve on. We'd be grateful for that. But yeah, that's something when we're out talking to communities, we always encourage them to have NAMI, you know, at the table from the very beginning. I know we've got some Kansas folks on the call today. They've done an amazing job at the state level and engaging, you know, their NAMI is very involved in AOT throughout the state and really supportive, and it makes a world of difference.
They actually have statewide like support group for families who have a loved one in AOT. It's a virtual support group, but I think that's an amazing resource.
And in terms of the check-ins with your program, that would be something you might want to encourage, especially it sounds like you've got a relationship with the judge there. Maybe, raise that idea with your program and see if that's something, because it really can be a really effective component of AOT and really make a difference for a lot of people. If your judge is interested in talking with other judges who use that as a regular part of their program, we can certainly help make that connection.
How often do you guys do check-ins, or does the court do the check-ins?
That's a great question. We'd like to hear from you all. How does your court do it?
Well, for us, our Fresh Start Court is held on the second and fourth Tuesday of every month. That doesn't mean every client comes every month. It's obviously an individual basis whenever the judge feels that that person needs to come back again for, compliance. Also, when speaking in terms with NAMI, our NAMI person is at every Fresh Start Court, handing out resources, offering resources, things like that. And that has proved very helpful, because a lot of the times at Fresh Start Court, family members will show up with the client as well. So that initial contact is something that has proven to be very effective with the family members.
Here in Ellis County, we do it monthly. It's the second Monday of the month, unless there's a holiday on there. And kind of like their program, we also have the NAMI peer support attend every single one, and usually gives a goodie bag to the first time attendees. That way they feel welcomed. I saw Amy actually bought that book. It's the I Am Not Sick, I Don't Need Help book is actually really beneficial. I would encourage people to have their centers buy it or something, just because it does provide some insight to this.
I also asked Brooke to put in the chat. We had Dr. Amador at the symposium in San Antonio, and he did a keynote, which is on our YouTube channel, but he also did a breakout session on the LEAP method, and Brooke's going to put the link for that video in the chat.
And you mentioned goodie bags. I know when Eric Smith, if you've had an opportunity to hear Eric speak about AOT, he's an AOT graduate from Bexar County, Texas, and has spoken at several of our functions. And but he always shares how one of the things he looked forward to in going to court was that they had muffins and coffee and juice kind of there for the participants. It was, a small thing, but it made a difference. I was in a program a couple of weeks ago observing, and they have a box of snacks that they keep right there, so when the participants leaving the courtroom, they can just reach in and grab a snack. But those are little things that do make people feel welcome and gives them a little something to look forward to. Other things you're struggling with, you'd like to bounce off your peers?
Okay, so I want to thank y'all for your response in regards to the potential like continued meth use and things like that. That definitely put that in perspective for me. So that I'm just nervous about the buy-in from my area director, because some of those clients are in residential, and there was a meth use on the residential property, as well as my judge in regards to meth use. Like we had a consumer came in high for the first court session, and he was very displeased. So I'm just kind of trying to figure out, like I'm understanding the information and everything. I just didn't know if anybody's been able to like disseminate that to other people, and just how to do that in like a concise fashion for people who don't have a ton of time, things like that.
Where are you from again, Linda?
Georgia.
Georgia. So the AOT rules should not be the same as the residential rules. Let the residential folks enforce their own rules. It's not the AOT program's role to do that. I know that anytime someone's housing is at risk, it really is the treatment team's problem. I get that. But sometimes you just can't, you can't fix everything for the person. And I think that that's the hardest lesson for any case manager or treatment team, because if you can't fix it, that means it's going to be a mess down the road. And I get that. So I don't say that lightly, like just ignore it. Speaking of judges, next month we are having a judges conversation, and only judges get to attend that. But I would encourage your judges, because you will get notice of it. Your judge probably isn't on our list. Maybe they are, but they probably aren't. And it would be a good place for them to ask their peers how they manage that situation, because it's not just your issue, it's theirs as well.
Okay, and you said we will get notice of these things, because I'm kind of like a, the go-between between the different departments.
You bet.
Yes, I'll make sure you get it, Linda.
Thank you.
It'll go out in our March bulletin though, so keep an eye out for that. Usually comes out the first week of March. Has anybody had that happen where somebody appears in court and they're been using drugs and aren't able to engage? I'm just curious how your judge handled that.
We had the consumer do that, and Judge Boone ordered, I think he ordered a screen on the spot, not necessarily a substance use screen, but like just a mental health screen due to the person not being coherent. We weren't sure if it was drug induced or mental health. So kind of just ordered that for his own well-being. And it was substance use induced, but also not taking medication as prescribed.
So both.
Yeah, they ended up going to Lawrence State Hospital, got out and back on the routine. They're doing good now, but.
Kate, you wanna?
Yeah, I have a couple of questions. Has anyone ever had, so we have to have the, one psychiatric assessment for the AOT petition. It can happen at the actual hearing or before. And for those individuals who are get violent when they get confronted by police, has anyone ever had a psychiatrist or it would be a psychiatrist go to the individual to do the assessment? And then also, as far as interfacing, has any of you actually go to, or your ACT team go to the person's home or provide them rides themselves or anything like that?
In my county, in my role as the AOT monitor, Kate, I see every respondent at least once before their court hearing, and as I noted before, at any point in which their treatment is being threatened with things like eviction or non-compliance, and other types of things. So it highlights the fact that each AOT program is very different. Our program has a significant emphasis on the AOT monitor, and that's me going to see people at home and bringing the court to their home and emphasizing the need for treatment. That's in stark contrast to Marla's Fresh Start Court in Summit County. Both are extremely effective. Both are just very different models. But I view my role, and I come from a case management and therapy background, is whatever has to be done to help a client, I do. So I've I've plenty of times, well, I always do home visits, plenty of times driven people to appointments. Last week I ran down the street to chase after somebody to try to convince them to meet with their case manager to go to an apartment viewing, etc. So every program is different, but ours is predominantly home visit based.
Wow, thanks.
Ours is also mostly home visit based, and we have one psychiatrist who will do home visits. Another psychiatrist is only remote, but they can send a nurse to do the home visit, so that way they can get the injection at their home.
Ours, I'm in New Jersey, AOT or IOC. We do rely on face-to-face interaction, so we do go out to the community to meet with the consumer, whether that's going into the residence or agreeing on meeting at a particular spot. And when needed, we do assist with transportation if, in this case, their insurance can't cover it or they don't have the means to. And before they go to court, we bring them to our office where they see our psychiatrist for an assessment, as our psychiatrists will be testifying in court as far as their progress and how they're doing with their treatment plan.
Excellent. Other questions or things you want to share? I know I saw Sarah Hyatt on here. Sarah, are you still with us? Let's see. She might have dropped off. Oh.
Yes, I am.
Oh, hi, Sarah.
Hi.
You guys have.
Sorry. I'm kind of having to multitask. I'm so sorry. I'm a one-man show here.
Good to see you.
You too.
Hey, you guys do something different. I'm just curious if you can share a little bit about how you encourage people to stay medication adherent with folks who are on injectables.
We do have a subset. Well, let me just say, we have a large amount of people on AOT, or we call it outpatient community probate in Hamilton County, Ohio. We're right now at well over 200, I think around 250 right now. So we have a subset of that group that are on long-acting injectables, and we go through a process to determine whether or not they're effective for that particular client. And so I am the probate services director. I work with all the agencies here in Hamilton County. So I don't really have hands-on. I have to rely on the information I get from them and the hospital. So I have a huge network of people I work with on a daily basis, and including the Hamilton County Sheriff's Department, which are vital to our program. And with respect to the injection piece of it, once a person is in the hospital and the provider determines that the long-acting is effective, then they usually reach out to the case management agency or to my office. And together we make a decision whether or not to place them on this list. Once they're on the list, then the agency has the responsibility of keeping up with their schedule. I can't do that, but then they will contact me if the person's late, and our deputies will go out and get them and take them to the agency to have their injection administered. If they are combative or are going to require restraints, which doesn't happen very often, then they'll have to go to, we have a partnership with our psychiatric emergency services in Hamilton County. But this is just a subset. It has been effective. We've done the data, and we have cut down on both arrests and psychiatric hospitalizations with this program.
And if they refuse, they're not combative, but they just refuse, then what happens?
That's when they're picked up.
Okay.
And so what we've learned is one-time pickup is a real great deterrent. They will come on their own after that. We have one that actually calls PES and says, you know, bring my shot over there. I'll be over there at a certain time, a certain day, because he likes to go on weekends. Our deputies are probably a little bit unique in their role. They're assigned to the probate court in Hamilton County. They work with me on a daily basis. So we all also have other pickups, like we do evaluations if people go missing for over 30 days. We haven't picked up if they decompensated out in the community. So this group of deputies has come to know our frequent flyers, and they have a great relationship with them. Some of them have their cell phone number. And they know how to deal with this population, and they do it very, very well and very empathetically and very, very, very sensitive to the situation.
Thank you. Has anyone seen cases from people who were in criminal court and being, needing to be restored to competency and having those cases sort of dismissed and transferred to AOT? I know there's a lot of talk about that in Ohio. I'm just curious if you're actually seeing an increase in those kinds of referrals to your programs.
Be curious to know if anybody outside of Ohio is doing that as well.
Yeah, no.
I'm inside Ohio. This is Sarah again. We have them every week. We have one tomorrow on our docket. We have finally established what I think is a pretty good process. We're trying to watch them on the front end, try to get them, because these are not necessarily people on AOT. So we don't necessarily connect them with the idea of placing them on AOT. We just want to make sure they're connected to services in the county before they go to their hearing. And then we're trying to watch on the back end what's happening with them, because for a while we were seeing just a cycle of walking out of the hospital and going back into the jail, because they're just trespass charges for the most part, but they have their favorite places. So we are trying to capture that, kind of wrapped our arms around them on the back end to make sure that they are compliant in the community. But we have a lot of referrals through the municipal court.
Melody's got her hand up.
Hi, everybody. So I'm in Milwaukee, Wisconsin. We don't get a lot of referrals, but we've had a few. We actually have maybe 2 or 3 actively on our caseload. So we have a few mental health criminal institutions. So basically, obviously, when the competency is questioned, they're taken out of our local jail or local correctional facility and sent to the state mental health facility. And the expectation is that once they receive treatment, they get to a point where competency is resolved. And so sometimes that doesn't happen, obviously. And so we actually just had a recent one where the doctors determined that the competency wouldn't be resolved. And so what happens is, before they're released from the institution, which is in another county, they pretty much secure a civil commitment. And then once that civil commitment is secured, basically wherever their home town is, they'll transfer it. And so that's pretty much our process. And so what happens is, before they're released from the mental health state institution, our team goes and do an assessment, introduce themselves, and just begin to make that rapport before they even brought back to Milwaukee County. And then if it's possible, they start the discharge planning before they're released from the institution. So when they are transferred here, they can pretty much hit the ground running. So we don't get them too often. We're in our 3rd year. So I think we've probably had maybe 3 or 4 of those type of cases referred to us.
Thanks, Melody. Yeah, will be interesting to see if, if these numbers start to increase as more and more people get, get the hang of it and get word out there that this is an option. Well, I see we're about 10 after 4, so I don't want to keep you all too long. Just one last time, if anyone has a question and something that they wanted to share before we sign off. Anything else? Well, thank you all so much. This has been a great discussion. Really appreciate you being here and sharing your expertise with us and letting us know where, if don't ever hesitate to reach out to us if you've got a question or need something, or you've got a story you want to share, or you've had a success and you think others might be able to benefit from. We'd love to hear those stories as well. Awesome.
Absolutely. And
Thanks,
have a good
everyone.
weekend.
Thank you.